thank you so very much for coming back. See, I have to be invited, but for you, you have the choice of just, but thank you very much for coming back. And this subject is, I'm fairly passionate about this subject. And all what is going to be listed in this subject are not scientific facts. These are opinions, and these are questions from myself and from all of you that will shape this presentation. But my job is really to put that in front of you and have you ask the question, whether it's to me, to your friends, to your family, or to yourself. So again, this is not presentation about studies and research and here are scientific facts. This is mainly opinions and questions. Again, the definition of ethics in general is actually the moral fitness of any decision we make. So you ask yourself a question, is it ethical to do this or that in any aspect of life? And then when you decide about something, the fitness and the morality of that decision is what makes it ethical. In general, what drives these ethics is actually social circumstances, religious circumstances, a civil code or common understanding, behavior that is considered correct, especially in a particular group or a profession or individuals. For example, there is a code of conduct amongst criminals. That's an ethical decision on their behalf because it's a code of conduct. You don't snitch and you don't steal from your fellow thief. So really, it is a social group or a behavior group or something. So really, it has nothing to do with medicine. It has nothing to do with religion. It is a code of conduct amongst a group or a profession or individuals. When you talk about medical ethics, it is a group of these decisions that are within the values of the practice and the judgment in medicine. So you take these guidelines, so to speak, or these morally accepted decisions, and you take them into the practice of medicine. Now, the question that comes up all the time in the practice of medicine with liberty and justice, is that for all or that is for few? So here's a question. I'm glad you answered the question. Remember, I don't know if you missed, you were here at the beginning, but this is not scientific. This is mainly opinions and questions. So the answer was with liberty and justice for all. Do all of us here get the same health care? So is that considered morally or ethically acceptable in the field of medicine? We don't know. So my job is not to answer or to share my opinion. My job is to put this in front of you so you can ask yourself the questions. Do healthcare providers speak and understand the language and concerns of patients? They may speak the same language on the street, but when a patient has a certain concern and they cannot voice it that way, can the patient speak in a certain way that their healthcare provider understand what they want to tell them? Okay? So, doc, I really, really do not want to feel bad. I just enjoy fishing and enjoy going to the graduation of my grandkids next spring, and I want to do this and I want to do that. Should the physician understand they don't want to have aggressive chemotherapy that would debilitate them tremendously, so they won't be able to go and enjoy? So really there is that disconnect. Is that a moral issue where physicians and patients cannot speak the same language, even though it's in English? How has our society and culture have shaped our moral, ethical, medical values based on certain religious beliefs? And do other cultures or communities have a different medical values because their beliefs are different or their society is different? For example, every patient who get respiratory failure in America needs to be intubated. You go to China, you go to India, you go to Afghanistan, that doesn't happen. So which one is morally correct? Or is it the society that has dictated these medical ethical values? So are our values dictated because we are here? Are they different across a different continent? In Canada? In Mexico? Should they be different? I don't know the answer to this. Is it a constitutional right or is it a privilege? It is a privilege. Why is it a constitutional right in different countries that are not as rich as the United States? Again, this is an opinion. I'm not seeking answers. Okay? So these are questions that I want you to really ask yourself these questions. Should we be for a constitutional right to have equal health care? I don't know the answer to this. Or is it a privilege because you are this, then you get this. But since you are not this, you get this. I don't know. Should it be a personal responsibility? Or a social responsibility or a government responsibility? You go to certain countries, if you smoke, you don't get coronary bypass. Flat out. If you smoke, you don't get an organ transplant. So, should we impose personal responsibility on patients? Or should a group, the neighborhood, Lynn Haven, say people who smoke in Lynn Haven and they need a heart coronary bypass because we really do not want to spend a lot of money on somebody who's going to need a coronary bypass, but they're smoking. We are the citizens of Lynn Haven. We're going to have a responsibility that we're going to deny this coronary bypass. Should that be the case? I don't know. Or should the government, of course, we need more government regulation and more government intrusion and to tell us exactly how to dress up and how to do this and how to do that. But should the government be the one to dictate this? Okay, so who would say yes, the government should be? Who say the government should not be? Okay, so here's a piece of information. Most of the medical bills for certain groups of patients is paid by the government. So the government can mandate, if you smoke, you don't get coronary bypass. Before your coronary bypass, we're going to get a urine nicotine test. Okay? Now, we should be free. Remember, this is the land of the free. I am free to do anything I want to. Or, I feel great. My neighbor's got 17 million diseases, but I feel good. That's all what counts. Or is it all the above or none of the above? So these questions will shape our thinking process in the medical ethics and how we practice. I don't want to give a breathing treatment to this patient because I can see the pack of cigarettes. The moment he feels better, he's going to go outside and smoke a cigarette. That's not the patient. Okay? So it's really very important that we really shape how we think and build our belief process in the medical ethics based on what we see around. And you can have in this room, you can have people from the far left, literally, to the far right, literally, and somewhere in between. And I can tell you, if I do a survey pretty quickly, you will see that is at the end of this presentation. You'll be amazed with the responses that we're going to get. So, before I get into these typical, interesting interchange cases, I wanted to share with you the definition of DNR. How many people think they know the definition of DNR? I want to see hands. Okay. I would say a third. Okay. So let me define DNR for you. DNR, we use it. We're a healthcare provider. We use it. But it is not for us. DNR is an exclusively a patient initiative and right and prerogative that translate into English, please leave me alone. Please get out of my room. So we, as healthcare provider, should not use the term DNR. That is not for us to say. That is for the patient to request. So it's actually a patient's right and request. Stay out of my room when my time is up. Do not touch me. Do not invade me. Do not violate me with intubation and line and shocking and chest compression when my time is up. So it is a patient's right. I cannot say, you DNR, because that's not my right. That's not my place. DNR is actually a patient's choice to protect themselves from aggressive and futile therapy. And I want to focus on the term futile. Futile means it doesn't make any difference. Therapies. The physician has to agree with such decisions in the presence of a terminal illness or a devastated state. So when a patient requests, I want to be a DNR, the physician has to agree with that decision. And I will share with you this in one of the cases we're going to present down the road. Because patients can say, I want to be a DNR. Physicians may disagree with them. Now, the other thing that I want to share with you is the term terminal weaning. And piggyback on the presentation earlier today in the ICU medicine, sometimes we try to help the patients. We try to do what is necessary to reverse a major illness or a devastating illness. Then after trying, and we do this, and we get every tool and equipment in the storage room that I know how to use and not know how to use, and we apply it to that patient, and things don't work out. So patients may have a pre-directed guidelines, or the family may say, it's about time, we want to have something called terminal weaning and extubation. And usually it is reserved for patients who have terminal irreversible illnesses. Somebody come in with a small stroke. A day later, that stroke expands and bleed within that stroke, and the brain is devastated, and the patient is now on a respirator and expected to remain on the respirator for the rest of their life with a PEG tube, and going to be total dependence on other people's care. The family may say it is time to extubate that patient, and it's called terminal weaning and withdrawal of care. And it is also a patient's right to die peacefully and naturally and limit life-sustaining treatment. Sometimes it is a physician-driven recommendation, meaning you sit down with the family or you sit down with the patient and say, this is the realities of your illness. This is the realities for the future. What do you want done? We recommend that it is time to stop putting your loved one through unnecessary procedures, unnecessary measures to sustain life. So sometimes we tell the patient, ma'am or sir, your son, your daughter, your mother, your father had a devastating stroke, and now they're bleeding into the stroke, and we cannot do this for them, and we cannot do that for them. It is time to really stop what we're doing and focus on comfort. So that is a choice or recommendation we make for patients. Now, one thing I wanted to share with you after I told you that it is a patient's right, we also have rights. So we have the right not to resuscitate a patient if the family or a family request that we do it knowing death is expected. Meaning that we have a patient that has terminal COPD, advanced lung cancer with mets to the brain and to the bone and to the liver, and that patient is not expected to do well. And they go into a cardiac arrest. And the family is there. I said, Doc, I want you to shock, resuscitate, chest compressions, and do everything you can and everything you have. Bring the dialysis machine, bring the ECMO machines. We want everything done to save our loved ones. Physicians do have the right not to resuscitate. I can say, I'm not going to do it. Well, doc, you have to do it. I don't believe that that is the right thing for your loved one. I am not going to do it. We have the right to do that. Most physicians do not take that confrontational stance. Remember, our patients, our relationship with our patients is a covenant relationship to do what's right, ethically right. And I'll show you how ethics may or may not be different based on societies. So I have taken a stance at times where I choose not to resuscitate a patient, knowing that the family said, doctor, do the chest compressions and so forth. We know we will break the ribs and put the patients through unnecessary pain and suffering. The definition of medical ethics is a study of competing values that are held by patients, physicians, and society. So you may have three different sets of values and beliefs that they compete when it comes to the bedside. I am pro-choice, and he or she are pro-life, and we have a patient. Okay. So the medical ethics in general provide physicians with a structured approach to resolution. So what we have these ethics, so we can have kind of a guidance and some certain metrics that we can measure these questions against and decide what is ethically correct or appropriate. So medical ethics is a system of moral principles that apply values and judgments to the practice of medicines. So these are kind of well-known principles that we take everything we do and measure against these principles. When we have a patient-doctor relationship, patients are very vulnerable, extremely vulnerable. They're fatigued, they're tired, they're shocked, they're not in belief. Doctor, is this my test or somebody else's test? Is this my blood work? Is this my CAT scan? So there is a lot of vulnerability with this illness. And sometimes the education of and the knowledge and the experience of the physicians should be packaged and provided to the patients. So, the patient doesn't know what is the genomic treatment for a 3CB chemotherapy for lung cancer. And they're not expected to know. That's not their field. They may be PhD in engineering or rocket science, but they don't know this genomic treatment. So we have an obligation to share our education and knowledge and experience with these vulnerable patients and explain to them what's going on. And good physicians will have the ability to sit down with the patients, and the patients will feel comfortable with them and will share with them and talk to them rather than talking at them or talking down to them. They will talk with them face to face. And a lot of times with what we practice, and I noticed this in my practice of medicine, that when a patient is in bed and it's about a major decision, when you talk to the patient, you always talk down to them. Always. Metaphorically. Sir, you're going to be fine. Or sir, you got this. You're always talking down to the patients. So if it's a major decision or a major issue, talk with the patient. Sit down at the edge of the bed and really earn the trust and the confidence of your patients, and then they will have the trust and confidence in you that you know the diagnosis, you know what you're doing, and the therapies you're going to recommend is appropriate. Now, you know who that is? That is the most famous military leader on the face of this earth. Alexander the Great. He conquered from the Atlantic Ocean to the Pacific Ocean, going through all the way. He died at age 35. And his famous saying is that he died from a lot of physicians. So sometimes a lot of physicians is not a good thing for the patient. When you have a lot of cooks and a lot of recommendations and a lot of guidelines and a lot of values, that is sometimes counterproductive for our patients. So that is one of the nature of a relationship, and that's why you see patients are connected with one doctor. They're emotionally connected. They know my doctor is so-and-so. I trust you. You're great. You're the best. You're published. You're known. You're 5 stars. Your reviews. But I really want to talk to my doctor. Part of the component of the relationship between a doctor and a patient is the characteristic of the patients and the physicians. Certain patients have certain characteristics. They understand certain cultural language, certain social language, religious language, and certain physicians have also certain tones to talk to the patient. So this relationship is governed by who we are and who the patients are. And these characteristics evolve over time and have a lot to do with the society, how we are as a society. 50 years ago, there are certain things that there's no way we were allowed to do, and if you do, you are considered a murderer and you will be taken to the electric chair. Today, these things are being done, and really not a lot of questions being asked. Euthanasia, for example. So 50 years ago, you cannot imagine somebody talk about euthanasia. Today, there are some states are considering euthanasia, assisted killing, and so forth. Again, this is not saying right or wrong. This is not my opinion endorsing one thing or another. I'm putting this in front of you. It's opinions and questions. The modern American medicine reflects the science and the morals of the American society today. Every patient who's got renal failure will eventually need to be on dialysis. If I walk to a patient's family and I say, your loved one is in renal failure and we will not give him dialysis, that could be the end of my career, from having to fight and having to have legal defense and so forth. But this is the norm in some other parts of the world, with no questions asked. Is it because these are our society and this is the moral values and expectations in our society and they're different in another society? I don't know the answer to this, and I don't know what is right or wrong. Is my decision right or wrong medically based on our society and the understanding in our society? Every patient will need to be intubated. Every patient will need to be defibrillated. So if you're driving through Atlanta or walking through Atlanta Airport, there's an AED almost in every corner. And if you have somebody who's 90 years old with metastatic cancer and walking and they drop and you put that AED on them and it says, we advise to shock. Would you shock that person? Should that be the norm? But this is the Atlanta Airport norm. Everybody gets an AED and everybody get evaluated, and if it's a shock, you shock. And I don't know the question to that or the answer to that, but one of the things that I thought the reason for the AEDs is sometimes the flights are so close together and you have a very narrow time and you have to run from one place to another so fast and people get heart attacks. So maybe they need to take the AEDs and give us more time between flights. So the doctor-patient's relationship, it always should be acting on the best interest of the patient. But who to say what is the best interest of the patient? My beliefs, the societal beliefs. If my beliefs are different than the societal beliefs, but I have to act on the best interest of the patient, and always is required, because patients sometimes cannot really make a decision. So, doc, what do you advise that I need to do? So these patients trust their physicians. These patients trust the judgment and the knowledge, and they have confidence in their physician and have the utmost trust in their physician. So they're asking me for my advice to operate or not to operate, to dialyze or not to dialyze, to intubate or not to intubate. So now the burden of that decision has come to my shoulders to give them the proper advice based on my values. Which is interesting, because we certainly see in the medical community here that certain physicians have certain, I'm not saying right or wrong, have certain beliefs, and the reflection of their work on their patients reflect those beliefs. Absolutely. So that very same patient can see 2 different doctors, have 2 different therapies based on the beliefs of these 2 doctors. The patient-doctor relationship should always be fiduciary, meaning that you always look for the best for that patient. And it's based on altruism. I am always going to be honest with you. I'm always going to be fair with you. I will treat you like my family member. And I will do the best that I would do for myself or for my family member for you. That should be the guidelines on how a patient-physician relationship should be. This is the Hippocratic Oath. Now, do you think physicians should abide by the Hippocratic Oath based on the social acceptance? You know, everything, did they not graduate and swear to the Hippocratic Oath? Let me see some hands. Nobody thinks that physicians should abide by the Hippocratic Oath. You heard that. This is, okay, let me see bigger hands, higher hands, so I can see. Okay, I would say half the people think that we physicians should really comply with the Hippocratic Oath. Is that correct? Okay, so let me start. Apollo is the ancient Greek god that lives on, I forgot which mountain. So now we physicians who believe in God Almighty are going to have to swear by God Apollo. How accurate that is. But 50% of you believed, based on the social information, that we should we should swear by the Hippocratic Oath. But the Hippocratic Oath has some guidelines, and it's really a very powerful document. The reason is it was the first document ever written in the history of medicine that continued to be today, that transcended time, language, continent, geography, culture, religion, gender, medical entities, that really should be the framework of guidelines. Because the last part of that document is we now have the government today have drafted probably about 1 million pages of regulations with HIPAA. You know, you hear about HIPAA, 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 HIPAA. No, you can't pick your nose. It's HIPAA compliant. Okay? But the last part of the document exclusively talk about HIPAA 4,000 years ago. That when you walk into a house and you see things, you should not share with anybody once you get out of that house. So the components of the doctor-patient relationship should always transcend time and transcend cultures and transcend language and religion. You always have to do what's right. Now the question is, what's right is defined by the society or by the community at that time. This is a book written about the doctors, my colleagues. And when I was a doctor, one of them was alive, so literally my colleagues. Nazi Germany doctors that did horrible human experiments. Because at that time, in that location, it was okay, it was the standard, the ethical practice to do what they did. So these guidelines, ethics, have to transcend the feeling of right or wrong, has to be universal, and has to be unequivocally changed based on religion, culture, location, and time. Physicians have to have 3 elements of C's. The first C, you always have to know and to be willing to be compliant with all the rules and regs. And you know, if you go to hospital A, they give you about 700 pages worth of bylaws, and you do this and you don't do that, and you do that but you don't do this, and so forth. So you have to know the rules and regulations, and you have to be willing to comply with them. Then you have to have conscience, where you really practice those rules and regulations and guidelines. You do them. Last but not least is your conduct. Your conduct is when you do the right thing when nobody is watching and there is no rules and regulations and your supervisor is not overlooking your shoulder. So these are 3 guidelines that really should shape our, I'm talking about physicians, but should shape our ethical conduct when we're practicing medicine. So it requires that the physicians is the person who can be expected to habitually act in the best interest of the patient when no one is watching. Those Nazi Germany doctors were not acting in the best interest of those patients, even though from their ethical standpoint of view, it is accepted at that time in that location to do what they did. But here, as a general guidelines and a universal guideline, they should act in the best interest of patients when nobody's watching. So back to the point to re-emphasize, we as physicians, our relationship, or as healthcare providers, our relationship with our patient is a covenant, is a sacred relationship, is a handshake that I'll do the best I can for you. It is not about you sign a contract with a hospital, with a nursing home, with a entity and say you do this and you don't do that. Yes, sir, no, sir, no, sir. So I'm going to share with you about 4 interesting cases. Again, these are opinions. This is a case that I personally dealt with about 15 years ago. A man came in at the side of his son who was convicted and about to go to prison on Monday morning. And on Sunday, the son decided that he wanted to commit suicide. The son has been in jail before, and he was raped in the jail when he was in the jail, so he did not want to go back to jail because this sentence was a much longer sentence, expected to be in jail for 20 years. So he decided to take his own life, so he took a handful of pills and he became unresponsive and needed to be intubated. His father was standing next to me and he told me, my son is a DNR. Do not intubate my son. And now I have only 1 minute, literally 60 seconds to decide what should I do. Should I intubate the patient? And the father is sitting, Doc, my son is a DNR, I'll really prosecute you if you touch my son. He is, do not resuscitate, do not intubate, do not shock, do not touch. What should I do? I have 60 seconds, so I'm starting to count for you. Intubate. Who would say intubate? So, okay. I would say 30% would say intubate. Who says do not intubate because he's a DNR and you should not violate his civil rights? Huh? So the majority would said intubate. So I'm not going to tell you what's right or wrong. I'm going to tell you what I did. What I did is I went back in my mind and re-understood and recited for myself what is the meaning of do not resuscitate. Do not resuscitate is a patient's right to don't touch me, please leave me alone, please do not violate me, do not intrude on my privacy and my health. So when the dad said, do not resuscitate, that's what came to mind. But the 2 words that came back also is futile and terminal illness. That was not the time for me to investigate why is the father saying this about his son. But I know the son does not have a terminal illness, and I know my efforts are not futile because within 24 hours the effect of these medications would wear off and the patient would wake up. Completely normal. Now what happens afterwards, it is a social event that should not blind me from really taking care of the patient. So I intubated that patient. And the patient eventually woke up and was released from the hospital. What happened afterwards, I really don't know. But the point is, it has to be, a DNR has to be, physicians have to agree that it's futile and you have an irreversible illness. Now, this is another interesting case, also happened with me. A man was in his 60s, came in, and he was having progressive kidney disease and needed to be on dialysis. And we were about making preparations for dialysis. He said, well, I think my son would want to give me a transplant. So the son was a rich person. He flew on his jet, came from Louisiana to the office. We did some preliminary work, and we found out biologically that that man, the son, cannot be the son of this man. Okay, so now here I am looking at this, and I have a HIPAA issue. Whom should I share the secret with? What should I tell the son? What should I tell the father? These are my patients. I ordered the tests. So who owns that secret? Whom should I share that secret with? Huh? Who would say the father? So I got 4 hands say the father. Who would say the son? Okay, so I have 5 hands. Who would say the mother? Okay, I got 5 hands. So here's the issue. Here's the issue. That HIPAA secret or that HIPAA issue belongs to the mother. So to the son, I said, you cannot donate a kidney to your father. You have a blood mismatch. For the father, who's also my patient, I said, your son cannot give you a kidney because there is a blood mismatch. Should I have privately met with the mother? Who? Okay, so here's what I did. Some people say yes, and some people said no. I did not meet with the mother. I don't know if she knows or not, but that's not my secret to share with them. Case number 3. You have a special skill that you can start an IV or put a central line, and the state of Florida calls you because of your skill. They need you to start an IV on a person that has been convicted for capital punishment, and he's going to need to be executed tomorrow, and you have that skill to start an IV. Would you do it? Yes. So, who would say yes? Okay, there's no grading.
Do we get to find out what he did?
Okay, you're not, who would say no? Who would adamantly say no way? Okay, so here's the question. Do the people who said no, do they believe in capital punishment? No. So now you noticed how your belief would shape how you practice. In the same room, in the same city, in the same time, in the same social circumstances. So medical ethics is fairly a variable issue. So the question that and this is a hypothetical question, I've never been asked, that when I am asked of such, I am not asked as a doctor, but I'm asked as a citizen that has the special skill. I cannot go and with a lab jacket, I'll go, sir, I know how to do, or ma'am, I know how to do this. And the society have condemned that patient, not me, have decided that that's what the punishment should be. So if I am part of the society and I believe that is a fair punishment, then I would do it. And I'm not going to tell you what I would do. This is a very interesting case, case number 4. Case number 4 happened to me about 8 years ago. I was working in the ICU, and the ambulance brings a young man, 28 years old, from a triathlon that has massive intracranial hemorrhage. Massive. Zero chance of survival. The patient is from Jacksonville. And the patient is engaged to be married. He is the only child of his mother and father who are multimillionaire. And he is expected to inherit about $80 million. And the patient was so intelligent, he got accepted to Harvard Medical School. And that was in April. School starts in 3 months. And he was, like I said, engaged to be married, so he sent his fiancée with 10 of her friends to Rome for a bachelorette trip. So he comes to the ICU massive intracranial hemorrhage, and literally was not expected to live for longer than 24 hours, blood everywhere inside the brain, and about to herniate. So within 12 hours, his fiancée had a private jet from Rome come to the United States and was right there at the bedside. So she took me to the side privately and asked me to collect some sperms. Okay, so what should I do? Huh? And to make it even more entertaining, she offered me $10 million. Well, so what? So any hands, any takers? Yeah, should I do him or not? So the point is, maybe she wants to have a son from that man, or a child, or a girl. And because they're about to be married in 10 days. I saw the wedding invitations, and she was on a bachelorette party, and his parents said, yes, this is our future daughter-in-law.
If she had 10 mil, money would have been no there.
So should I say yes? Huh? Okay, so here's the deal. From an ethical standpoint of view, and this is this transcends through time, cultures, ethics, money, state, county, redneck Riviera, you name it. She is a fiancée. What is she legally to that person? Who is the person to call the shots? His mom and dad. So number one, she has no right into anything. Number two, when, let's say she is a wife and she wants to collect sperms, can I do it? She's legally the wife. The answer is absolutely not. The reason is we don't know whether this man wants a child. Maybe he is planning to divorce his wife. Maybe he doesn't want children. Maybe he never wanted children. Maybe he doesn't want children with this wife. So when you are a legal guardian, there are limitations to what you can give the permission to do. Because our relationship with patients is to do what's right for the patient. It's not a contractual. You work for the hospital, you collect the sperms and give it to the mother and father. No, I know the patient may not have wanted this. He may not have wanted children. So, with these questions, if you want a repeat of this, you can see this again if you have any questions or comments. But these are opinions and comments. I may not be the right one to give you answers. Thank you so very much for your attention. No questions? You got everything? Yes, ma'am. Yes. So she asked a very important question. And the question is, if a physician does not agree with the patient, does that strip the patient from the right to say a DNR? Absolutely not. The agreement of a physician has to be based solely on the belief that the patient has a terminal, irreversible illness. Now, here is, if you say you are going to be a DNR and you're young and healthy, and I disagree with you, if something happens to you, I will overcome your decision and resuscitate you because you don't have a terminal illness. So it has effectively taken you right away only if I disagreed with you based on the fact that you do or do not have a terminal illness. But if you have a terminal illness, my agreement is going to be automatic. And if you have a physician who will not agree with you, you fire that physician and get one who will agree with you. But you have to have that terminal illness. Just to say, well, I'm a DNR, I'm done with this life. I'm paying too much of this, or huh?
Well, look, I have Alzheimer's in my family. I have a living will. My living will states to be a DNR. If that comes up, and because I'm afraid of two things, pain and stupid. I do not want to live 10 years stupid. That I want to be a DNR. I don't want anything extending my life. I don't want blood work. I don't want x-rays. If I can't swallow it, I don't want it. That's me. Do I need to go out and hunt for a physician who will agree with it?
You have a terminal illness. It's called Alzheimer's. See, when you can speak and you're not stupid as you have mentioned, then that DNR is not effective. Now, if you, God forbid, you have a cardiac arrest now, and I heard what your living will said and how intelligent that question was, I will resuscitate you.
Well,
Do you want me to resuscitate you? Do you want me to resuscitate you?
I have not been diagnosed as having any kind of...
Now, this is a real question. If that happens, do you want me to resuscitate you?
Since I have not been diagnosed with a life-ending disease, yes.
You would agree, even though you have a DNR and I violated her DNR?
No, my DNR would start at that time.
Yes. Yes, ma'am.
Is there a fine line, the question of terminal illness and therapies that aren't going to work, as to whether the physician, say an oncologist, is certain that their treatment will work, even though it's going to put the patient through things they don't want to go through?
So the question is there a fine line, or is a line between that we have exhausted all reasonable therapies, or should we try everything? Remember what I told you, just because you have therapies in your storage room or in your pharmacy doesn't mean we have to try everything on everybody at all times. What is now comes to your trust with your oncologist and their ethical conduct about altruism. Altruism is when you have, as a physician, in your heart, the best interest of a patient and not the financial interest. So there may be a doctor up in North Dakota who will give you chemotherapy and will charge your good insurance $20,000, but we know that doesn't do much except make you lose your hair and this and that. So that doctor is not driven by altruism, and he will have a nice web page, nice Facebook page, and people are going to see them. And there is no value in these therapies. So if you trust your physician and you trust their altruism, which is I would do for you what I would do for my sister, my mother, my daughter, then that should be enough. Yes, ma'am.
I had a patient, they had been in a long-term care facility decades. The family that had put them in there had all died. There was no plan for their care after those people were gone, literally not a living relative. And I was asking various people, who's making decisions? I could never get a straight answer. When that happens to a person,
The courts usually so the question is if somebody has no family members, who makes decision for somebody who is incapable of making their own decisions? And the answer to this, usually the court appoints somebody who is totally emotionally and socially disconnected with that patient, but we have the covenant relationship with that patient to do what's right, and we have the right not to give somebody a therapy if we believe that that's not gonna help. So you have to have physicians who understand this code of conduct and this ethical conduct. Looks like one more question.
Why would, if a patient has a DNR status, the family that has rights be able to override that decision?
This is a very complex issue. How can family override a patient's wish? And in my opinion, and again, this is an opinion, when a family knows that their loved one wants to drink water and doesn't want to drink coffee, for example, and they intentionally force things on that patient that he or she have specifically mentioned they don't want to have done, they have the legal right, but they don't have the moral, ethical right to strip their loved one from his desires and his wants and don't wants and do's and don'ts. So it is really an intrusion not from the physician, but from a family against their loved one.
Because we've had patients that are DNR, but we had to code them because the family says do everything.
Even though the patient said, so there are I will put case number 5 very quickly, I think, very quickly. We had a patient that his wife wanted to torture her husband. He had a DNR, and he had a DNR, and she wanted everything done, chest compression, shock in his heart, VTAC, VFib, shock, electrocute, one. Okay. So it's not the physician, it is the patient's family who's making this. I'm sorry, these are questions. Yes, sir. Somebody had a question. Yes, sir. So if it is a Jehovah's Witness patient, what should it be? As a provider for critical care medicine, I had to read and educate myself about Jehovah's Witness and what is allowed, what is not allowed. Plus, I have the number of the medical liaison office to ask and consult with what is allowed or not allowed. Sometimes you have to, if a patient has a terminal illness, Jehovah's Witnesses will sign themselves as a DNR and will allow limited resuscitation if somebody does not have a terminal illness, excluding blood and human blood transfusions and so forth. But the understanding of medicine is appropriate, but not wide. You don't do everything that you have. You do what is reasonable. And remember, all goes back to the altruism and the covenant of the patient and the trust of the patient and the family. Thank you so very much for your attention. I'm sorry I went over.